Hi and welcome to Physiotutors podcast, episode 62 with Barbara Cagnie. Barbara is a physiotherapist and manual-therapist and a professor at the University of Ghent with a special interest in the treatment of neck pain. She has published lots of papers on the topic, including various studies on dry needling, which is the topic of today's podcast. Hi, Barbara. Welcome to the podcast and great to have you as a guest.
Okay. Hi.
Welcome. And as always, I have prepared quite a few questions, so let's get going. My first question, Barbara, is, and that's a question to start out, could you please explain to us what dry needling is and also what it is not, so that we have a definition to start?
Okay, dry needling is a technique that is mainly used by physiotherapists to treat myofascial pain. And with dry needling, a thin filiform needle is inserted into the muscle onto a specific trigger point. And the main aim is to decrease pain and to restore muscle function. Other indications are treatment of patients with neurological disorders and scar tissue. It's very often compared to acupuncture, but the philosophy to use this technique is quite different. Acupuncture is based on the traditional Chinese medicine, whereas dry needling should be seen as a tool within the toolbox of healthcare providers in the management of musculoskeletal pain.
Yeah, clear. And you have published a paper on the physiological effects of dry needling, which caught my eye. Could you tell us what is the physiological basis of dry needling? And I have a couple of extra questions like how does it work? How does it decrease pain? What is the function behind that?
Okay, dry needling has several effects, both peripheral effects and central effects. Most studies have investigated the peripheral effects of dry needling. But in order to understand the underlying mechanism of dry needling, I think it's important to shortly describe the pathophysiology of the development of a trigger point.
Yeah.
The most common hypothesis is the so-called integrated trigger point hypothesis, which is originally developed by Travell and Simons, and then further expanded by Robert Gerwin, Jan Dommerholt, and Jay Shah. So first you have the development of the taut band. And studies have demonstrated that due to muscle overload or trauma, there may be an inhibition of acetylcholine esterase. That's an enzyme that breaks down acetylcholine, which results in an increase of acetylcholine in the synaptic cleft.
Yeah.
And as a result, high-frequency miniature end plate potentials occur, which can be determined experimentally with needle electromyography as spontaneous electrical activity. So we see an increase in spontaneous electrical activity. And this increase and also the increase of acetylcholine leads to an increased release of calcium at the level of the sarcoplasmatic reticulum. And this causes the sustained contraction of the sarcomeres. So this leads to the formation of the taut band. And studies on rats have demonstrated that dry needling at the exact trigger point may increase the release of acetylcholine esterase, which decreases the acetylcholine release. And this is also reflected in a lowered spontaneous electrical activity of the muscle. And as a consequence, there's a relaxation of the muscle. So this is the first effect and the most investigated effect, and which nowadays, they know that this is really an effect of dry needling, a peripheral effect of dry needling. A second effect is on pain and inflammation. So due to the sustained contraction, there's a capillary constriction, which leads to local ischemia. And this results in decreased energy supply. On the other hand, due to the ongoing contraction, the muscle needs a lot of energy. So you get a disbalance. The reduced energy supply in combination with the increased energy demand results in an energy crisis. And as a result of that, inflammatory mediators such as bradykinin, prostaglandin, serotonin are released, and this stimulates the nociceptors. And activation of those nociceptors release again other neuropeptides such as substance P and calcitonin gene-related peptides. And these changes causes the local pain upon palpation of the trigger point. And there are several studies and studies on rabbits also that have demonstrated that dry needling may increase the beta endorphin levels in the muscle itself and in serum, accompanied by a reduction in substance P levels of the muscle and at the dorsal root ganglion. And this is mainly the case when one dosage of dry needling is given. If, however, dry needling is performed for several consecutive days, there seems to be also an increase in the number of hypoxic responsive proteins, which may promote angiogenesis and increase the capillarity in the skeletal muscle. So the second effect is mainly that dry needling has an effect on pain and on inflammation.
Yeah.
And then lastly, you have the central effects, but those central effects of dry needling have been underestimated or understudied until now. The main information is coming from the acupuncture literature. I can sum up some central effects that are supposed to play a role. For example, the gait control effect, which is supposed to mainly occur by using techniques such as winding or in-situ, which are not really pain provocative and may stimulate beta fibers. Other effects are the conditioned pain modulation and changes in skin conductance and heart rate frequency, but these results are rather contradictory. And of course, lastly, as we have with all hands-on techniques we use within physiotherapy, you have the placebo effect, which may not be underestimated when you use dry needling. So a lot of effects.
Yeah, interesting. I mean, it's similar with manual therapy, where in the past we only talked about local effects, and now it's so much more about what's going on in the supraspinal structures, and also taking placebo into account as well.
Yeah, I think the neurophysiological effects are the main effects of dry needling, but even and also for other techniques that we use.
Yeah, I had another question. You mentioned quite some studies, so you can measure what's happening in the trigger points, right?
Yes.
And those were conducted in animals. Do we have any human studies?
There are human studies, but to look for the underlying pathophysiological mechanisms of dry needling, most of the studies have been done in experimental animal studies. So there are some human studies, but it's quite difficult. So there are some biopsy studies that have been done to investigate what is happening in the muscle. There are some microdialysis techniques that have been used to investigate, but it's not really easy to first identify the real trigger point spot, or objectify the trigger point spot. And so the studies with biopsies and so on are not easy to perform.
Okay, and when we talk about trigger points, because that's a bit the next topic that I want to get into, the literature or the books describe or distinguish between active and latent trigger points. Could you explain what the difference is between those two?
You have indeed active and latent trigger points, and I think the main differences are that active trigger points give spontaneous pain at rest during movement or compression. They give local pain, and they give the referred pain that is the recognizable pain for the patient. It also may give a jump sign or a local twitch response, which you don't have with latent trigger points. Latent trigger points only give pain with compression or movement, so no pain at rest. And the referred pain, so you can elicit it referred pain, but this is not the pain of the patient. And most of the time, active trigger points are associated with greater zones of referred pain and higher pain intensity than latent trigger points. And maybe to add, there is some discussion in the literature and also clinically whether we should only aim to target those active trigger points or also the latent trigger points. And in my opinion, I think everyone agrees that we should target the active trigger points, but identifying and treating latent trigger points may be beneficial in targeting the whole chain of the patient, I think.
Okay. And if we look at the reliability of finding trigger points, and especially if we look at the inter-rater reliability between two examiners. I've seen quite a couple of studies that show that reliability is low, which is a problem, I guess. Can you explain a little bit about that?
Yes, there is indeed no unity in the scientific literature regarding the reliability of manual palpation. Several studies show low to moderate inter and intra-rater reliability. There are some studies that have shown that it has good reliability. Quite recently, I think it was in 2020, there was a Delphi study on diagnostic criteria of myofascial trigger points, which was performed with 60 experts over more than 12 countries. And they identified a cluster of 3 diagnostic criteria as essential for the trigger point diagnosis, which was the identification of the thought band, identification of a hypersensitive spot, and inducing the referred pain. Eliciting a local twitch response did not appear to be a good criterion, but recognizing the pain was the most reliable criterion for diagnosing myofascial pain. So there's still a lot of doubts whether we can palpate it or not, but it's contradictory in the literature.
Yeah. Looking at the manual therapy research as well, I think when we look at hypomobile segments, that was quite a challenge as well. And in the literature, what I saw is as soon as it's about pain or pain reproduction, then our reliability goes up quite a bit.
Yeah, it's similar. It's really similar to what we see in manual therapy techniques. Yeah. It's a kind of manual therapy technique as well.
I mean, it is. Yeah, sure. It's always dependent on how broad you use that term, manual therapy, indeed.
Yeah.
And we already talked a little bit about the phenomenon of referred pain. How does that work in trigger points? Because what we were taught in our manual therapy masters, for example, was that referred pain is always referred from a region of low density of efferent input to a region of high density of efferent innervation. And then if I look at muscles are highly innervated.
Mm-hmm.
How does that work? Do we have any idea about that?
The most plausible explanation of referred pain nowadays is that we have to look at the dorsal horn, is that sustained nociceptive impulses from the muscle, that they may activate the NMDA receptors at the dorsal horn, and these are normally inactive. And if they are activated by sustained nociceptive impulses, this may activate other wide dynamic range neurons and activates silent synapses, which is accompanied by an expansion of the receptive fields. So an increase in the receptive fields is the underlying mechanism of referred pain. For example, I give an example of the soleus muscle. This soleus muscle may give referred pain to the sacroiliac joint. And the explanation is that first, nociceptors in the trigger points of the soleus induce local pain. But if there is sustained nociceptive impulses, then they are retransferred to the spinal cord neurons belonging to the segments of L5 and S1, which are the normal relay stations of the soleus muscle. And excitation spreads in the spinal cord, and in this way, the normally ineffective connections between the soleus muscle and the neurons which are below, of S2, S3, S4, they become effective. So this can activate neurons in S2, S4, and that provides sensory innervation to the SE joint. And in this way, the patient may also experience pain in the sacroiliac joint. Maybe just one side note, I think it's better to speak of referred sensation than speaking of referred pain, because a trigger point can include different sensory sensations and not just pain. For example, dull ache, tingling or burning pain, but also dizziness or tinnitus can be a referred sensation of trigger points.
Yeah, very interesting. It's a bit of a different mechanism than the convergence projection theory. So it can also refer from a distal area to a proximal area,
Yeah.
which like talking about the convergence projection theory is not possible, and it can also go from basically from with the projection convergence projection theory, it's always from a spinal structure to a distal structure to an extremity, but this can also be different in trigger points.
Yeah, but there were different hypotheses, and this was also one of the hypotheses. But as I said, I think the most plausible explanation is this increase in receptive fields.
Yeah. And continuing, if we look at the local twitch response that many patients experience with dry needling, or that the therapist is actively looking for, is this something that is necessary for successful treatment, or is it not necessary?
Yeah, that's a good question. So a local twitch response is a very brief, sometimes painful contraction of a taut band in the skeletal muscle that is elicited during dry needling. Sometimes it can be elicited by a manual palpation as well, but that's rather difficult. Studies have demonstrated that dry needling could effectively suppress the spontaneous electrical activity, which I've mentioned before, when local twitch responses are elicited. However, several studies show that eliciting a local twitch response does not correlate with changes in pain and disability. And there are multiple systematic reviews that have failed to conclude whether the local twitch response is relevant to the outcome of dry needling. Local twitch responses are mainly elicited when using the fast in, fast out technique, or it's also called the hung technique, where the needle is repeatedly moved up and down in the muscle. And these techniques are mainly used in patients with subacute or recurrent pain.
Yeah.
And we have clinically the impression that the effect some hours after the dry needling is often better than when no local twitch responses are elicited. But due to those local twitch responses, which are painful, we often have post-needling soreness. And for that reason, in patients with chronic pain, it's better to use techniques which do not elicit local twitch responses and those post-needling soreness. And in these cases, other techniques such as needle winding or needling with needles left in place are recommended.
Okay, and needle left in place is the in-situ technique, I guess?
Yeah,
right?
That's the in-situ technique.
And what is the winding technique?
The winding technique is a technique where they also put the needle in place or in situ. They leave it there, but they often rotate the needle. So it's left there for a few seconds, for a minute, for example, and then you rotate the needle and then you leave it again there. And the needle is left there for 15-20 minutes. And that's a technique that is mainly used in the treatment of scar tissue.
Okay. So different techniques for different treatment goals.
Yeah, absolutely.
Yeah, I think the discussion about the twitch response, again, I'm referring back to manipulations or mobilizations, is the same, like the cracking sound, the cavitation.
Yeah.
In my opinion, what I know from research is it doesn't matter, but then still in practice, if I have a patient and it doesn't crack, I feel like the experience is different for them. So I don't know how much of an impact it has on the placebo, for example, or on the belief of the patient, what actually was done to them or what happened in their spine, for example.
Well, I think there are two things. You have indeed a placebo effect, but on the other hand, and that's very difficult, I'm a clinician and I'm a researcher as well, and I think it's very difficult to investigate what we exactly do in clinical practice. In research, we have to use randomized controlled trials. We have to be very strict in what we use. Whereas in clinical practice, we work patient-centered, we work patient-tailored. We don't use the same technique in every patient. So if sometimes we can't demonstrate with scientific literature or evidence what we see in clinical practice, and maybe that's a frustration for me as a clinician and as a researcher. And that's not only for dry needling, but as you say, that's for a lot of techniques that we are using.
Yeah. And you already touched on the treatment of different tissues, such as not only taut bands and muscle tissue, but scar tissue. And I've seen some research where they already started dry needling tendons, for example, for tendinopathy. What is your opinion on that?
It's indeed true that dry needling is mainly used for treating muscles in patients with musculoskeletal pain. But nowadays we see that it is more and more used for other conditions. So regarding tendon dry needling, this is a somewhat different technique compared to the penetration of the muscle belly. It involves repeatedly fenestration of the affected tendon, which is thought to disrupt the chronic degenerative process and encourage localized bleeding and fibroblastic proliferation. There are some systematic reviews and randomized controlled trials, mainly in the regions of the wrist and the rotator cuff, the patellar tendon, and around the greater trochanter. But I think based on those studies, there is initial support for the efficacy of dry needling for tendinopathy, but I think really high quality studies are needed in the future. And I have no clinical experience with treating tendons in this way. But what we also see more and more is that dry needling is also used for scar tissue, as I already mentioned, and also for neurological disorders. There is more and more research and a lot of systematic reviews nowadays and controlled trials in patients with neurological disorders, mainly in patients with stroke, where dry needling is used to work on the spasticity of patients in the lower limb and in the upper limb. And it has been demonstrated that dry needling in those patients improves spasticity, decreases pain, and improves the range of motion. However, these effects at this moment have mainly been evaluated in the short term, and so especially after stroke. And then for scar tissue, there is only clinical evidence at this moment. There are no scientific studies that have evaluated the effectiveness of this method in research. The underlying mechanisms are not fully understood, but they assume that when applying mechanical stress by inserting, and so using that rotation of the needle into the scar tissue, that you stimulate the fibroblasts and encourage the realignment of collagen bundles to the direction of stress. So it is assumed that dry needling in scar tissue can improve microcirculation, muscle blood flow, and so on. So I have seen quite a lot of cases. I don't use it myself, but I know that there are some people that use it a lot in people with chronic scar tissue. And you see some amazing results in case studies. But again, I think there's a need for further studies to provide evidence for this technique.
Yeah, I mean, especially with spasticity and the mechanism that you described earlier, I can totally see how this makes sense at first glance. I mean, if a muscle is contracted and you want to release it, I mean, that makes sense from my point of view. And moving on, what is the evidence in general or in different musculoskeletal complaints regarding dry needling?
I think if you look at the literature, the last couple of years, a lot of systematic reviews have been published on the effectiveness of dry needling in different regions of the body. And what we have done in Ghent, in order to summarize all those systematic reviews, we have made an umbrella review. So an umbrella review is a review of systematic reviews where we looked at the evidence of clinical effects of dry needling on musculoskeletal disorders across all body regions. And to shortly describe maybe the main conclusions, I think we can say that dry needling is superior to sham or no intervention. and equally effective to other interventions, and mainly for pain reduction at the short term. Results on physical functioning outcomes such as improving range of motion, improving strength, improving motor control, these outcome measures are more contradictory across body regions. And also nowadays, limited data is available for mid and long-term effects. So mainly effect on pain reduction and mainly on the short term. What we also see is that in the beginning, dry needling has often been investigated as a solo treatment. And nowadays, more and more studies look at the additional value to the interventions that are used in clinical practice. So several studies have shown that that there's an additional treatment effect when you combine dry needling with other physiotherapeutic interventions compared when you do an intervention in isolation. And maybe just to add, and that's maybe because it's my area of expertise, I think the strongest evidence for dry needling nowadays exists for neck pain. Maybe the reason is because that region has been investigated most, but there is strong evidence that there's a superiority of dry needling for the reduction of pain intensity and mainly, again, on the short term.
Okay, this is quite interesting for me because, and that's from the top of my head, I think the latest KNGF guideline on neck pain, I think they did not recommend dry needling for neck pain. I'm not sure if you're familiar with the Dutch guidelines.
Yes, I'm familiar with that, and I argued. I argued against this guideline with some people who wrote the guideline, because they based it on 4 papers to make this conclusion. And I think the latest paper is from 2015. So my main arguments against is that they just made use of 4 papers to make that conclusion, whereas there were at that time already a lot of other papers. And mainly in the last 5-6 years, if you look, there is an increase in evidence. So I think that guideline should be updated.
Okay, so your expectation is that it will find its way back into the next guideline or into the updated version?
I hope so.
Yeah. And this is also the point where I will say to our listeners out there, all of the literature that we talk about will be added to the transcript of this podcast. So you can find all of the links to PubMed. I will ask Barbara later for a little help to find all the papers, and we'll put it in the reference. So no worries. And Barbara, feel free to throw out all of the papers and studies that really add value to this podcast.
Okay, I'll do.
And looking at contraindications, what are contraindications of dry needling? I've seen some horrible videos of pneumothorax. This is maybe the worst contraindication, but are there others? And how high is the risk really?
There are indeed some major events after dry needling, but I think mainly what is described after dry needling, which is again quite similar to spinal manipulation, is minor events. There are some case studies, and indeed the pneumothorax is the most known severe complication of dry needling, and there are some cases described in the literature. The other major complication that is described is this excessive bleeding that you can induce with dry needling. But there has been a study of boys also quite recently who collected information related to minor and major adverse events that occurred during more than 20,000 dry needling sessions performed by over 400 physical therapists. And in 1 of 3 cases, in 35% of the cases, minor events, adverse events were reported. So small bleeding, bruising, pain during dry needling. And from those more than 20,000 dry needling sessions, there were 20 major events. So the pneumothorax and the excessive bleeding. I think, and that's the reason why I think it's important if you want to perform dry needling, that you have to follow a course and a good course to perform dry needling in order to to avoid those adverse events. And knowing your anatomy and knowing where the muscle is located and knowing what is surrounded by that muscle, where you are not allowed to perform dry needling, is very essential if you perform dry needling and if you follow those courses. And if you talk about contraindications, I think there are not a lot of contraindications. There are some contraindications, of which the most important are infections or increased risk of infections, edema, and then skin and blood flow disorders. I think these are the main contraindications to dry needling.
Okay. I won't refer again to manipulations. Maybe a last time. It's also the same story. If you're not qualified, don't do it. I think that will avoid a lot of harm, I guess, in general, and I think that's true for other treatments as well. And dry needling is one option to maybe relieve a taut band. What about the pressure of my hands? So I haven't done a dry needling course yet. I'm still on the edge. I'm still on the fence. So yeah, what can you say about that?
That's a good question, because I very often get that question. If again we look at the literature, then there are some studies that have compared manual pressure release to trigger point dry needling, but most of these studies could not demonstrate a difference between both techniques. However, most studies investigated the superficial muscles, which can be approached both manually and with dry needling. The question is whether you can access deeper lying muscles with manual techniques. And there exist no studies that have investigated the difference between manual pressure release of deeper lying muscles and dry needling. So for superficial muscles, there's no difference based on the scientific literature. But again, in my clinical opinion, clinically there is a difference. But most of the time, a better effect of dry needling compared to manual pressure release. But this is currently not supported by evidence.
Okay, yeah, I can tell you a personal story maybe. So I had quite a tight, or I had pain in my quadratus lumborum, and I was sure it's the quadratus lumborum. And I think I had like a couple of days left for a tennis competition on the weekend. That's when I called a friend to do some dry needling on my quadratus lumborum. And I was like, okay, this is really a case where you don't release anything with your fingers. And I have to say it helped me quite a lot. So I was kind of pain-free a day later probably. So that kind of made me curious about dry needling.
Yeah. And did you get a serious local twitch response?
Oh,
because
it was
that
insane.
muscle is very...
that was insane, yeah. So I almost flew off the bench.
Yeah.
Hey, and moving on, and I think we already touched a little bit on it, and that's also a bit of a critique that I have personally, and I think critics of manuotherapy, but also dry needling, is that it only has a short-term effect. And I think if I add my personal critique that I have, and I also see that with manuotherapy, people do an expensive course because they are quite expensive, at least here in the Netherlands, and then they end up only dry needling everything. And it's a bit the same with manipulations and mobilizations. You do a master's here, it costs you, 20,000 euros. And then people only do that. That's a bit the beef that I have with passive treatment or with manuotherapy. What's your opinion on that?
I think that there are two things in your question. I think the first thing is whether it has only a short-term effect and what is the effect, and whether it is used as a standalone treatment or that it should be combined. I think I've already said that based on the evidence, I think it's indeed true that dry needling mainly has a short-term effect. Yeah. That's also the effect that has been investigated most. And in my opinion, I think dry needling may be seen as a tool in the early phase of treatment in order to create a condition to start exercise therapy or to start other therapies. So dry needling is not a standalone therapy. And the problem, again, in scientific research is that it very often investigated as a standalone treatment, but there are more and more studies that have investigated the additional effect of dry needling. So, in my opinion, it's just a tool in the toolbox of the physiotherapist that can be used in a multimodal treatment approach with a sound clinical reasoning, and it can be used mainly in the short term to create a condition to start other kinds of therapy.
Yeah, and I think your answer blends with my next question, which is, what would be your top 3 reasons to learn dry needling as a starting physiotherapist or as a physiotherapist in general?
Well, the first reason is indeed what I already said. I think in this way you learn a new clinical skill with more and more evidence that can be used as an additional tool within a sound clinical reasoning. What I really learned during my dry needling course is my anatomy knowledge enhanced a lot, because you can't perform dry needling if you don't know your anatomy. So you learn or relearn to know the exact location of the muscle, the origin and the insertion. But you also learn the different layers of muscles, and you also learn to think 3-dimensional. So I think that's what I learned most during the dry needling courses. And I think a third reason, which is also in line with the second reason, is that it increases also your palpation skills.
Yeah, I've heard that one during an ultrasound course that we did as well. Like, you really start to see muscles or the body in 3D.
Yeah.
And we learned everything from a textbook, which is 2D.
Yeah, absolutely.
So it's really different.
Yeah, absolutely.
Yeah, I think my personal reason to learn dry needling is because I see a lot of sports people who have to get better quickly or who want to get better quickly. And yeah, there's a lot to say about only focusing on short term, but there are cases when there's people who play, I don't know, high competitive sports who need to be a little bit better or get a little bit better on the weekend, like taking my own case, for example.
Yeah.
I think that's where it's also personally interesting for me.
Yeah, absolutely. Absolutely.
Okay, I'm looking at the list of my questions and I'm almost through. I have like one final question, and it's basically, what is the future of dry needling? And I'm also looking at different versions of dry needling, like electrical dry needling, for example, or ultrasound guided dry needling. Yeah.
I think there are different things for the future. I think, first of all, we should further increase the evidence, looking how dry needling might be implemented as an additional technique and knowing when and when not to apply it. I think about ultrasound dry needling. I think ultrasound can be a very nice tool to learn dry needling. But I'm not convinced that this should be incorporated in daily clinical practice, but more to learn the dry needling technique. Yeah. And with respect to electrical dry needling, this is somewhat another kind of technique that can be used. Also, the evidence is not quite supportive, but in electrical dry needling, this is mainly used for patients with chronic pain, where they again put the electrical needle in place and put some electric current on it with a burst TENS to mainly have a speedier analgesic effect. So this is already implemented. So I don't think this is not a new technique that needs to be investigated in the future. And then maybe lastly, and not sure if this counts for all countries, but it does count for Belgium, is I think we should convince medical doctors that physiotherapists have the skills and the knowledge to perform it. That's for me an important message, because that's still quite an issue in Belgium, but maybe also in other countries.
Yeah, I don't think it's an issue in the Netherlands, or I haven't heard it, but I know in Germany, you're not allowed to stick anything into a patient.
Yep.
And you have to be there's like an alternative healing education thing in Germany that's going on, that a lot of physios, they take that route, so they are allowed to apply other modalities such as dry needling, for example. So yeah. And I already said it, we're coming towards an end, and I always ask our guests, is there anything that we haven't touched on yet that you would like to add to this podcast?
No, I think we have talked about the different aspects of dry needling, I think. So I think we have discussed the different things. So for me, it's okay.
Yeah, I'm also happy with it. So if you're happy, we are happy. So final question, if people want to know more about you, where can they find you?
They can just find me on the internet with my name and with UGent. UGent is is the University of Ghent is my origin. So they can find me there, and they can find the different publications as well.
Yeah, are you active on social media as well?
Not a lot.
Okay, so better to send
an email, then I respond.
Okay, great. All right, Barbara, thank you so much for your knowledge and for your time. It was a pleasure.
Thank you for inviting me. It was a pleasure as well.
Okay, and for everyone out there listening to this episode, thank you so much for joining. And as always, to access the transcript and additional resources, make sure to download our new and free Physiotutors app and benefit from more useful physio content. And if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts if you're listening from there. And also consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll see you in the next episode. Bye.